quite frankly, I really do believe it is an epidemic. And I would actually say that it's the pandemic that we don't talk about. We don't really want to know it's there.
Dementia, it really starts silently, and it starts decades probably before it's even apparent.
But then all of a sudden, like the memory is completely different. And the family says, they come in with a pneumonia or a urinary tract infection, and then this is not the same person that I was married to.
They've done studies where people who have good social connections are 30% lesser at risk of dementia and developing dementia than those who don't. Give everyone a 2-minute cognitive test.
Yes.
Only 50% of dementia is diagnosed in primary care.
Right.
It shouldn't be where a neurologist calls a primary care doctor and say, oh, well, your patient of 20 years, 3 times, 4 times a year has Alzheimer's dementia.
Personally, I hate the word Alzheimer's disease. People say, well, I've got Alzheimer's disease, so that's it. To me, that's the myth.
So basically, you're saying that Alzheimer's is not a normal part of aging. Welcome to Spectator MD. I'm Marvin Bass, your host. Today, we'll be talking about a very important topic, dementia and Alzheimer's. I have with me today a very special person who I've known for many years, an excellent neurologist in his own right, with plenty of experience, Dr. Paul Wright. Paul?
Marvin, good morning. Thank you for having me. This is really a pleasure, first of all, to catch up and obviously to discuss this important topic.
Thanks. Paul, I know I've known you for many years. I know your history. I know your experience. But why don't you just tell us a little bit about yourself through the years and your professional career up until this point?
Absolutely. So I am a board-certified neurologist. I trained at Mount Sinai Medical Center. Then afterwards, I went into private practice, and that's when we started together in the ERs at North Shore. I was in private practice for approximately 13 years. And then I moved over to the Department of Neurology at North Shore University Hospital, where I oversaw all of neurology for North Shore, LIJ, and all of Queensland, Long Island. Then afterwards, I moved over to Nuvance Health to build a neuroscience institute. So currently I oversee a neuroscience institute across Connecticut and upstate New York, where we manage all of neurology, neurosurgery, neurointerventional surgery, and PM&R and interventional pain for the health system, covering approximately 250 square miles over New York and Connecticut.
Excellent. All righty. So I'm sure things are going pretty well and you're pretty busy.
Yes, we are.
Yeah.
We're doing very, very well. We also started a residency training program so that we can actually start with the next generation of neurologists and train them in what needs to be done in this state of medicine and also in the country so we can provide best care for our patients.
Great. So obviously today we're going to talk about dementia and Alzheimer's, right up your alley. And as you know, I don't want to say it's an epidemic, but at the current rate, we have 6 million Americans with Alzheimer's disease today, with about 35 to 40 million worldwide. And they say in 25 years from now, it will be more than doubled. Okay, and not to mention the trillions of dollars that will be needed to care for Alzheimer's disease. So let's start by just defining the difference between dementia and Alzheimer's disease.
So I'd like to go back on what you just said by say, well, it's an epidemic, but really not. Quite frankly, I really do believe it is an epidemic. And I would actually say that it's the pandemic that we don't talk about. We don't really want to know it's there. But based on the statistics and based on the numbers, I'm sure that everybody that's listening to this podcast currently either has a very close family member that has Alzheimer's disease, or they have a friend or a neighbor that's affected by this condition. But yet, we all talk about, well, the memory's not as good as it should be, but it's there, it's on the forefront of everyday life. And to go back to what you're saying, the impact is significant because while we say, yes, the one patient has Alzheimer's or a cognitive issue, but that person is also surrounded by family members that takes up resources to be able to take care of them. So when you look at the overall number of Alzheimer's patients in the country, and these are the ones that we know of and actually have made it to the statistics, there's also a financial aspect on society that is astronomical. And based on what you're saying, that this is not going away. There is no cure. The numbers are increasing steadily. So by 2025, it's going to have a major impact on our country, not only financially, but an impact on just the community around us with facilities. Where do these patients go? How are they treated? And overall, we don't really realize the impact is going to be there going forward. But going back to your question, when we talk about Alzheimer's versus dementia versus mild cognitive decline, and it all comes down to a thing of semantics where we all don't like the word Alzheimer's. It has a negative connotation in society because we think that, okay, you've got Alzheimer's disease, that's it, it's over, and there's no quality of life left. And we'll talk about that a little bit later. But overall, when you talk about dementia, most of the dementias are actually Alzheimer's disease, and that is about 80% of individuals with cognitive decline in a certain age group over 65, they will have Alzheimer's disease. And dementia is mostly the umbrella and catchment of all of the cognitive decline illnesses. When you look at the other percentages, about 15% are maybe vascular dementia, which are caused by blood vessels and blood flow to the brain, which are impacting on people's memories. Then you start getting into the more uncommon ones like frontotemporal dementia and Lewy body disease. And those occupy approximately 5 to 10% of what's there. So overall, most of the cases, about 80%, are of individuals with dementia, senility, or cognitive decline actually have Alzheimer's disease.
Right. And how would you differentiate, let's say, Alzheimer's disease from Lewy body or even Parkinson's disease and vascular? What are there different symptoms of Alzheimer's patients than Lewy body patients or vascular patients or frontotemporal dementia? In other words, do the symptoms differ in the early stages or in the late stages?
And these are great questions that you're asking. And the first part of it is, let's take a step back and talk about, well, my memory's not as good as it should be. And I'm sure everybody here has gone into a room and said, oh my goodness, why did I enter that room? Or I'm rushing out and I can't find my keys. Now, does that make someone have a cognitive decline? And the answer is no, not in every situation. So I'm sure we all suffer from lapses in memory, and it could be multiple reasons why we have these lapses in memory. But that is not always pathological. In most of the cases, it's really not. But when we start having issues where it's starting to be a little bit more and it's impacting a little bit on the quality of life, then we can start saying this may be mild cognitive impairment. But then when we start seeing, well, wait a second, this is a little bit more. It's not only impacting on my ability to function at home. I am not understanding what to do with the microwave. I'm not understanding exactly where I put objects. I made mistakes and put wrong objects in the fridge. That's when we start saying this is more than just normal aging.
Right.
But,
I'm sorry.
yeah,
Go ahead.
But going back to your question about other aspects like diffuse Lewy body disease or frontotemporal dementia, a lot of the times these cases or these patients will come in, they'll be earlier in onset, they will have premonitory symptoms such as their hallucinations. Like, I'm seeing something that's not there. And like, oh, I'll just brush it off. But then it becomes more and more common. When other aspects come in earlier on, such as lack of judgment, like my spouse would never have done something like this. And now they're doing things like all of a sudden they're going on the internet and buying up 20 hats where he or she has never worn a hat in their lives.
Bizarre behavior, yeah.
Bizarre behavior
Right.
where the judgment is impaired.
Yeah.
Absolutely.
Yeah. So does everyone who ages have cognitive decline?
I would say that everybody who ages, the memory is not as good as it was when they were 16 years old. And overall, memory does decline as we age. But it does not always have to move into the pathological arena where, like this is something that needs attention. This is something that I'm worried about, a neurodegenerative process. And this is just normal aging.
Right. So you talked about, so basically we go from normal aging to mild cognitive impairment, and mild cognitive impairment, obviously progressing to dementia.
Approximately 10 to 15% of individuals with mild cognitive impairment will progress to Alzheimer's disease.
Like every year, so to speak, right?
Yes.
Yeah. What do you find as the most common first complaint that a family member will tell you about their loved one when they come in, as far as their physical or mental status?
And that's a great question because it's now changing a lot, because nowadays there's a lot of awareness about the new medications that are available. There's advertising on TV. So people are starting to question, like, okay, should I go get checked? So it's becoming more common now to go get checked. And as for the complaints, it ranges significantly. The things that I'm noticing is that it's really sort of interesting that we have patients that come in and they're always coming in and they're angry because they're saying, nothing's wrong with me. Why do I have to be here? And then I have a spouse and a son or a daughter saying, no, you've got to understand. This is what has been happening over the past 6 months or a year, and this is not normal. And then there's an argument that happens in the examination room where the patient says they don't know what they're talking about and they're just picking on me because I'm comfortable and I want to do just watch television and so forth. Then there's the other aspect where we have individuals that come in and say, I am missing things, and I know that normal aging, I'm supposed to sort of have some lapses here and there, but it's becoming more common. I'm misplacing objects. The other day, I forgot an appointment that I had to have, and it was a very important appointment. So when things like that take the next step where appointments are being missed,
more forgetful, right?
More forgetful,
yeah.
And things that are of importance that are obviously really relevant that people are missing.
Okay.
So then we have other individuals that come in and say, I'm not as good as I should be, but I'm missing important items. Like I missed the doctor's appointment that I had been waiting for a month, and I had it on my calendar, and I completely forgot about it. Then there's other things about, I'm getting these past due bills that I've always paid my bills on time, and now I'm making errors in bill payment. So there's sort of trends and patterns. I wouldn't say there's one absolute item, but then there's the patterns that are more important than anything else.
So you think that it goes from memory-oriented to non-memory-oriented, meaning it's starting to affect your daily activities of life.
Correct.
Confusion, like you said, misplacing something, not being able to find it, forgetting entire conversations,
Yes.
things like that.
And also, a lot of times spouses will say, he forgot the name of his grandchildren. And that's
Right.
something that 2
Concerning.
years ago
Yeah.
would never have happened. I mean, he loves his grandkids, and that would never have happened. Now we're starting to see that. But obviously, there's different situations where the patient could have been very excited or could have had stressors from somewhere else. So, like I said, it's not just one specific item. It's a trend of more than one item that you put together and you say there's a pattern.
Right. So now, obviously, dementia, it really starts silently. Would you agree with that? And it starts decades probably before it's even apparent.
That's a very interesting concept. So I would actually extremely agree with you that signs and symptoms may be there beforehand. Frequently, we see individuals coming into the hospital when a stressor occurs to the body, and you've had this experience where they come in for a basic non-issue of an infection that's very simple, but then all of a sudden, like the memory is completely different, and the family says, they come in with a pneumonia or a urinary tract infection, and then this is not the same person that I was married to. They've changed significantly. And obviously they chalk it up to either, in certain cases, the anesthesia post-operatively or the infection or the antibiotics, and people start asking, is it something with the hospitalization? But then when you sit down with the family member and ask them questions, and you say, well, a year ago, was everything okay? Like, yeah, just normal aging with memory. Or, yes, well, they made mistakes in bills. And funny, they started arguing with the neighbor who was best friends with them. And you start getting a good history that this is not just the hospitalization, but there was something there before that was very insidious, but really people didn't pay too much attention to.
Right, right. Now, I guess the challenge, right, is that, they say if you've seen one person with autism, you've seen one person with autism. And I think that can apply for Alzheimer's as well. If you've seen one person with Alzheimer's, you've seen one person with Alzheimer's, meaning that each person is different. Different, I think, in their presentations and different in the causes of Alzheimer's.
I would agree with you, and that's why people say, well, just come in and do a battery and do the check-off boxes. But I think if you do that, you're going to go down a very slippery slope, because we were always taught in medicine, take the history, listen to the patient. And in this case, to me, one of the most important aspects is to listen to the caretakers, the spouses, the friends, the family members who will give you the third-hand observership of that person. But going back to the history, we always have also the people who are what we call the worried well. Oh my goodness, I misplaced my keys. I must have Alzheimer's because my parents had Alzheimer's, so this is impacting me and so forth. But when you actually sit down and talk to many individuals, you'll find out there's a lot of impact on their lives that most people will not hear or listen to, because they walked into the doctor's office and obviously everyone's limited in time and rushed and so forth. And they say, well, your memory's not as good. Okay, then, and you go down the slippery slope. But when you actually speak to individuals and you say, well, what's going on in life? They'll say, well, recently my best friend died and I had to go to Florida and I was over here and I'm stressed about my home environment. And sometimes there's a lot of stresses on people's minds that the information that's coming in doesn't all get absorbed and people don't pay attention. So is it cognitive decline, or is it lack of attention, or is it depression, or is it other aspects that's causing this?
Right. In other words, so there's many causes. I mean, obviously, it could be hormonal, right? It could be infection. It could be depression, like you said. It could be maybe they had an ischemic event that they didn't know of, and that's changing their cognitive state. Pollution. So one size doesn't fit all. So I think you have to figure out what's causing the dementia or the cognitive decline. Is it normal pressure hydrocephalus? Is it a subdural hematoma? Is it anything else that we're missing? Right. So it's not you have cognitive decline, you have dementia, and, take this and be on your way. Because the treatment should be tailored, I believe, for the individual. And it should be customized according to them and to what age did it start? What's the family history, like we said? What are the insulting factors? I mean, we all know the end result. They talk about amyloid plaques and we talk about tau. And, the amyloid protein is the response to the inflammatory state. So there's people that they've seen on pathology that have amyloid plaques and tau that have Alzheimer's, and then there's people who've had amyloid plaques and tau who do not have dementia. That's another topic entirely. So can you elaborate on that a little bit?
Absolutely. So when someone comes in with the question about, do I have dementia? Do I have cognitive issues? I want to be checked. To your point, you're correct. This is not just a waste paper basket of just, okay, that means you're going down this pathway. You have to really understand not only the patient, you have to understand their medical history, what medications they're on, their habits. Do they smoke? Even though you and I know that smoking is bad, just last week I had a patient that said, can you tell my husband really why smoking is bad? So people sometimes don't understand how toxic their behaviors may be and their habits may be. Drinking. Nowadays, ever since COVID, where people had social isolation, we started seeing a little bit of an uptake in individuals that just felt more comfortable just having an extra glass of wine, an extra scotch in the evening. And then after a while, it was like, let me just have another one because I'm comfortable. I have the habits. Then one of the big things that I'm noticing nowadays is the rise of marijuana, where you'd be very, very shocked, where our residents are actually instructed that when you see someone coming in their 70s, 80s to the hospital, and things just don't make sense of why they're altered, the memory's off, do a tox screen on them to see if indeed there's marijuana, because it's available everywhere. And sometimes family members give their loved ones marijuana because they say, oh, it cures this, it helps with this, I take it, so it must be good for you. In addition, where do you live? What are your sleeping habits? What is your diet? Where did you work? What kind of exposure did you have to possible toxic components at work?
So the risk factors, right?
Completely going into the risk factors of individuals. Also, we ask, what was your education level? Did you complete high school? Did you go on to get a master's or a doctorate? What was your activity level while it worked? Because we do know that individuals with a higher cognitive level, such as a higher level of education, it's more difficult to find, number one, the signs of cognitive decline because they start automatically at a very, very high level. And plus, individuals who have had higher levels of education, they seem to do better overall.
Right. So let's talk about, I guess we're talking about it, but let's talk about the modifiable versus the non-modifiable risk factors, right? Mm-hmm. So the non-modifiable is
age.
Age.
Yes.
Right.
Unfortunately, that's impacting on every single one of us.
Right. I think they say every 5 years after the age of 65, there's a doubling of the risk of dementia. Mm-hmm. Second one is genetics, obviously. They talk about genetics, and we talk about the ApoE alleles. Mm-hmm. So these are obviously genes that have mutations. Can you talk a little bit about the ApoEs?
Well, going back to what you mentioned about the risk factors,
right,
and the non-modifiable ones, obviously we have the age. sex. It's more common in
In
females,
females,
than men.
correct.
Um, Obviously, genetics. We can't
And
choose our
why
genes.
is that it's more common in females? I would think is because they live longer.
That's a big
Right?
component of it, and they also they live longer. They take better. Women take better care of themselves than men, so it's more common.
Right.
Then we go into, obviously you can't choose your genes.
Right.
Sometimes it's almost non-modifiable is where we live. Is there a higher incidence in a certain location versus another location? But then we get into the modifiable risk factors. And these are things that we can do ourselves to make our lives and overall health better. The things that are the most common is high blood pressure, sugar, diabetes, cholesterol, things that we can actually get evaluated by our primary care doctors, and if we have these risk factors, change. Smoking, obesity, which plagues our nation. And we also question, is that one of the reasons why Alzheimer's is on the rise? Is it because of the obesity? Is it because of the gut-brain interaction with the processed foods that we're having?
Is it insulin resistance?
Insulin resistance has a higher risk of Alzheimer's disease than has been shown. And we don't know exactly why that occurs. And we ask the question, is it really because, is it the effects of sugar on the brain? Is it because of the gut-brain relationship? It's very hard to know at this point in time. But going back to other modifiable risk factors, the things that we don't even understand. One of them is a big one, which is exercise. The big E. There's no pill for that, I always say, and everyone's like, oh, what do you mean I have to exercise?
And it's the number one, let's say, drug, so to speak, that helps you the most.
Absolutely. Absolutely. And we can talk a little bit about that in a future segment. But when you also think of other things that people don't always pay attention to, and I always say, if you want to stay well, you have to eat well, exercise, sleep well. And sleep is an extremely important modifiable risk factor. And the amount of times that people come to me and I diagnose them with either a sleep disorder or obstructive sleep apnea or just lack of oxygen when they're sleeping is astronomical. And I always say that people always get upset when I start questioning about their sleep patterns. And they say, well, I don't have sleep apnea, or I don't have lack of oxygen during sleep, and I don't snore, and the spouses are rolling their eyes next to me. And I always say that people always say they're not a bad driver and they don't have sleep apnea. No one admits to these things. But this is one of the most important aspects of memory that needs to be addressed. And really, a lot of the times people do not address this. Other modifiable risk factors, obviously, diet. Well, is McDonald's and Burger King that bad for me? Yes, it is. These are processed foods, and not to name McDonald's or Burger King, but
we're naming them. In all seriousness, yeah. Well, really, there is no such thing as good fast food.
You will not go out and put diesel in your Ferrari.
Right.
Just because you need to have good quality of food going in. And people always ask me, well, what, so many choices, and I have the keto diet and this diet. And I always say, stop getting yourself crazed. Just start with a Mediterranean diet. Fresh fruits, fresh vegetables, whole grains,
fish,
lean meats. And, people will say, well, I have this habit of I like chocolate and everything else. And I'm like, okay, it's good, but everything in moderation. And it comes down to the part of just common sense. When you walk into a supermarket, and I think this is what I do, is I walk in when I see fresh produce and I see things that are just like appealing to the eye. Those are the things that your body wants, as opposed to things wrapped in cellophane and has more ingredients that are unpronounceable.
Yeah.
These are the things that make the difference.
Don't need anything in a package. Single ingredient foods.
Yes.
That's what I always say.
And that's
right?
what I would advocate too.
Single ingredient foods. And, people don't realize, if dark chocolate with a cacao greater than 70%, the polyphenols in there are huge. How important the omega-3s are to brain health. And they don't realize, you don't like fish, but take the supplements. These are things that people can do, because I don't believe that a person is diagnosed with Alzheimer's or is susceptible to get Alzheimer's through genes and their lifestyle, that they can't change that. And I think that half the cases that people who develop Alzheimer's can be prolonged or even prevented by the time they die through their lifestyle. Would you agree with that?
I would wholeheartedly agree with you on this. We have individuals who come in who are worried well about their memory, or they may have family members that have memory issues, and they start thinking, this is going to affect me. In the meantime, they're morbidly obese, they smoke, they drink, they don't exercise, they've not seen a doctor in 5 years, and they say, well, I'm worried about my memory. And I'm looking at, based on statistics, they're more likely to die of a heart attack or cardiac disease, which affects women more than men, kills more women than men, and that is not being paid attention to. So while people are worried about their memory and so forth, they're susceptible to many other diseases that are out there based on their habits.
And not only that, but if they change, in other words, if they exercise, if they stop smoking, if they lose body fat, and I say body fat and not weight, because I don't believe weight is something that should be measured directly, although indirectly. I think body composition, muscle mass is important. Increase in muscle mass, decrease in fat. Okay, it's been shown and proven that that's directly related to longevity, right? Your VO2 max, all these things that will increase longevity, increase your health, increase your brain function and brain health, right? We know it increases blood flow. Things that increase blood flow to the brain, like we said before, exercise, certain supplements. So there are definite things that people can do, and even more so if they have a genetic variant, which I think it adds to the cause. I think we know that if we go back to the genetic variants, the ApoE4, there's ApoE4, ApoE3, and there are ApoE2s, right? So most people are ApoE3, which is about 55% of the population, which is kind of a normal risk to develop dementia, right?
Correct.
Then there's 25% that have the ApoE3, one E3 and one E4. Right. And obviously you get one from your mom and one from your dad. So they have probably a double to triple risk of develop Alzheimer's.
But going back to that, just because you have the genes
doesn't
to
mean,
your point,
does not determine.
Exactly.
Right.
Because everyone's like, well, my mother had it, my father had it,
right.
my maternal aunt had it, and I have the gene if they happen to go get checked, and then I must be getting this, and I forgot my keys. But going back to what you're saying, the important aspect of all of this is that you're still not taking care of yourself, and you will end up with a self-fulfilling prophecy of increasing your risk for heart disease, diabetes, high blood pressure, and then instead of having the Alzheimer's disease, you'll end up having a vascular dementia because you increase your risk of stroke from these health risks that you never
even
took
before
care of.
you got Alzheimer's.
Correct.
Right.
Correct.
Yeah.
So I couldn't agree with you more, and I think this is what needs to be emphasized because people. I always like to put people in charge of their bodies, and when the spouses always say to me, "Well, what should they do?" and I said, "I don't know, but whatever makes them happy, they should be doing in terms of exercises and habits." Because when a spouse tells their loved one, "Go exercise," and you need to walk, and why are you not walking? Then to me, they say, "Well, I hate walking, and it's a chore." And then what happens is if it's a chore, it's not going to be done, and then you've accomplished nothing. And going back to the point that you were making before, can these things be turned around and changed? And the answer is absolutely yes. I've had individuals who've come in to see me and they smoke, they drink a little bit more than they should, and they're extremely sedentary. But not only sedentary, they actually don't even go outside to interact with people. And that's something I want to actually talk about. And
Social connections,
correct.
interactions,
Yes.
extremely important.
Extremely important, and I really want to get into that because that's something that we really don't pay too much attention to until recently. And I've had a one-on-one with patients, and I've said, look, I'm here to keep you away from the medical profession, to keep you such that we can actually do prevention, because prevention is the best thing that we could ever do. We're very, very good at treating diseases.
Excuse me for interrupting, but I remember years ago, and the motto was, or the slogan was that, neurologists it was where neurologists would say, diagnose and adios. In other words, right? We diagnosed it, but we can't do anything about it, so go home.
Yeah.
But that's not the case.
Not at all. Over the past 10, 20, 30 years, there's been an incredible influx of new testing, medications, recognition of diseases that didn't even exist before. So you're absolutely correct. But now we start understanding why people get these diseases. And to me, I wouldn't say burden, but the responsibility is for me to say to you, look, I am concerned that you haven't seen a doctor. When I see you just now, your blood pressure's elevated, and while it's not crazy elevated, it's still elevated, and over time, that is going to have an impact. Your sugars are not good, your diet's not good, you don't interact, your sleeping is poor, you don't socialize. And when we start talking one-on-one and people realize that I'm not saying it, like I always get the thing where people come and say, oh, the doctor shouted at me. Well, no, we never shouted. We never raised voice. This is concern. And this is the fact that I know that I can turn you around. And what's really nice is that people sometimes heed to what we're saying. And essentially, it's almost like being a coach. Because I'll send people out the office and I'll say, next time I see you, since we've had this discussion, I want a list of exercises that you've done, what you've actually taken up. I want a list of hobbies that you've actually taken up. That, you worked hard all your life. When you were working hard and you were saying, oh, I just wish I had time to do this. Now you have the time. What are you doing? How are you going to do it? I want to talk a little bit about social isolation and loneliness, because that's an extremely important concept that came about, I would say, just in the last year or two, that people were like, okay, so they're by themselves, and that's just the way of life. But we're starting to notice that, number one, there's an article that came out that showed that social isolation increases your risk of stroke. And loneliness is a major impact of what happened to our population after COVID. And it sort of stayed on where we sort of, well, this is what I'm used to. There's great streaming services on television. There's great programs that I can do. So why do I need to go outside? I can order everything from Amazon or any other organization. So why do I really need to go out? But what we're realizing is isolation, loneliness, has a significant impact not only on stroke prevention, but on Alzheimer's. And it's to the degree where we really have to take heed to this. But a very interesting concept is that you could be surrounded by many, many people and still be very lonely. And it's the concept of each individual person's feeling about what loneliness means to them. And that's something we bring up in discussion when I see patients.
That's interesting. Yeah. I firmly believe that loneliness not only increases your propensity to get Alzheimer's, but everything.
Yeah.
Heart disease, heart attacks,
Stroke.
diabetes, obesity, stroke. I mean, you name it, because it's a cascade.
Yeah.
It just, because one thing flows into the next.
Yeah.
You know, they don't realize social interaction and having a lifestyle that's meaningful, purposeful, useful, even in your older years, is so critical to mental health, physical health, emotional health. I mean, it's right up there with, does diabetes matter? Yes, it matters. Does body composition matter? Yes, it matters, right? Does ApoB levels matter? Yes, they matter for low cholesterol and for strokes and for even dementia, right? But social interaction matters. They've done studies where people who have good social connections are 30% lesser at risk of dementia and developing dementia than those who don't. I mean, it's really remarkable,
Yeah.
right?
Absolutely. And we're getting more and more data about this. But going into social interaction, one of the things that I want to bring up as a modifiable risk factor when it comes into the social isolation and social setting is hearing. And that's a very important aspect because, like, you're wearing glasses because you say, well, I'm a little blurred when I read, so I need glasses. But you'd be amazed at how many people don't hear well and don't go get their hearing checked.
And you know what I've heard? Excuse me for interrupting.
Yeah.
That up to 8% of cases of dementia
Yes.
are caused by hearing loss.
Yes.
Isn't that amazing?
What's amazing about that is a lot of the times the spouse will say, I told him to get ready because we're going out. In the meantime, he never heard. She thinks the memory's impaired. So that's one aspect of it. But the other aspect of it, which is very interesting, is that our brains need input. And that goes with our vision, it goes with the sensation that we're touching, and it goes with our hearing. So even though we may or may not be listening to something specifically, our brains are actually employing our ears all the time to gain input from society, from the community, from the environment that we may have not pay attention to because it's not past our threshold. But our brains are perceiving this, and that input has major impact on cognition overall.
And we take that for granted.
Absolutely.
Right? Because I find myself not hearing the way I used to hear 20 to 30 years ago. And I'm kind of disregarding it.
Yeah.
I mean, again, it's not that I'm not deaf or by any means, but it's just not as crisp. Mm-hmm. I'm sure you could say the same. I mean,
well, too many rock concerts will do
yeah,
that to you.
And too much time at the racetrack, with loud cars. It's just
Absolutely.
Even though earplugs help, but they don't solve everything.
Correct.
But no, you're so right. You're so right. And I can't stress how important these modifiable factors are. And if we only could follow this. And another thing I wanted to talk about is how relevant are the biomarkers? I know they play a role. In other words, but I think it's part of the puzzle. Cool. So you've got to put everything together. In other words, okay, he's obese and he has 2 ApoE4s, which increases your risk 10 times. Again, risk. It's not deterministic, right? And he smokes, and he has a p-tau 217 or A beta 4240. Do you want to just talk about those a little bit?
Sure, you're really piling onto that one patient as everything.
Yeah.
But for the most part, when people come into the office and with a complaint, well, the memory's not as good as it should be, or they're forgetful, I'm starting to be concerned about certain things, the key point is to start with the workup. And to your point of what you're saying, it's not just one aspect in terms of, well, there's a genetic marker, so ergo, that must be the case. You have to take into consideration everything. And we do the workup. I mean, the workup will do the history taking, which is very important, along with habits, which to me are extremely important. I always ask my residents to make a comment when they're speaking to patients. Find out what they did for a living. Find out who the person is. And if they're a high-performing individual and suddenly they retired 5 years ago and have done nothing, these are relevant things to taking a history. Then we start going into the blood tests. Is there something that's abnormal, such as thyroid? Is there lack of B12? Upstate New York and Connecticut, Lyme disease is endemic. You know, even though people don't always have the joint pain, the fevers and everything else, the amount of individuals that have Lyme disease is astronomical. So we check that as a routine. So we go through some blood tests that we can say, well, there's reversible causes. Then we start looking at, obviously we'll do a baseline MRI to see if indeed, is there something there? Are there multiple strokes that the person's had that's caused a stepwise decline in their memory because areas of the brain have died, for lack of a better term? Then we start going into, with the MRI of the brain, is there something there? Like, is there a tumor that has grown over time that's caused memory issues? And very rarely, but we still see them, people have had personality changes, memory decline, even hallucinations, even change in personality, where all of a sudden they've started to develop this incredible amount of anxiety and they've had a brain tumor. And obviously this is all being reversed. Then when we see that all these things are for all intent and purpose normal, then we start going into the next stage, which is, do we start looking at PET scans? Now, PET scans tell us the metabolism of the brain and what is there in the brain that is being used up. For example, like the first one we'd use was an FDG PET scan for glucose. And that's the metabolism of glucose in the brain, where we inject glucose with a flashing light attached to it. And we see where it goes in the brain, and there are areas of the brain where the metabolism is not so good, which would be indicative of
Alzheimer's or frontotemporal
Correct.
dementia or any
diffuse
other
Lewy
type
body.
of dementia,
Correct.
right? Depending where it is on the brain.
Correct.
Right.
Nowadays, we have what's called ligand studies, which I always equate it to like a Lego block. We're infusing a Lego block with a flashing light into the body, and it goes to the brain. And if there's a corresponding anti or that block, it will stick. And then that will light up in the brain. And that's what we use for amyloid. So we put in an amyloid tracer, and it goes into the brain and sticks to amyloid. And that will tell us if there's amyloid, which will be indicative of Alzheimer's. Very uncommonly, we do tau tracers. They're not so readily available as amyloid, and that can also be a test that we will do to see if indeed there's buildup of tau in the brain.
How about the regular blood markers for p-tau 217 and a beta 42/40 ratio? How beneficial are those?
These are becoming much more common nowadays. As technology advances and it becomes easier and easier to be able to just go into the doctor, take a blood test and say, oh, I have these markers, ergo, I must have Alzheimer's disease. I think with approximately 90% sensitivity and about 70% specificity, they're good. But there's a few caveats. You have to correlate it with the overall clinical picture, number
Right.
one. Number two is you also have to ensure that there is a confirmatory test, which would be confirm it with the CSF, with the spinal fluid, or with imaging of the brain.
So, excuse me for interrupting. So, how often would you do a spinal tap?
Nowadays, because of the PET scans are so available and so good, very uncommonly. Because number one is when we suggest this to patients, they're like, absolutely not. I'm not doing a spinal tap. So nowadays, between the blood biomarkers and the imaging, we can really shy away from doing that. Where we would do a spinal tap is where we're thinking of other causes, such as disruption of myelin, other rare diseases such as Creutzfeldt-Jakob disease, other issues such as infectious causes. That's when we
Maybe seizures that you don't know where they're coming from.
More towards that. But what's interesting is that when you get down to all of this testing, you've got to make sure that, number one, when you're doing a blood biomarker, that it is a reputable blood biomarker. The second thing is you have to make sure that it's going to be covered by your insurances, because not all insurances will cover these things.
Yeah.
And many times we've had patients that come and say, I want this, I want this. And I always suggest, please clear this with your insurance first, because while people promote it, the effects on that may be significant for individuals with all of a sudden they get thousands of dollars worth of bills. So I think it's always worthwhile and prudent to make sure that you know what's being covered.
What happens, obviously, when we go down the road and we're further down and now the person has full-blown Alzheimer's, where he's exhibiting all the symptoms? And how do we manage these behavioral symptoms?
That's a really great question, and obviously a very difficult question to answer, because again, these things go into an individualized basis. First thing when I speak to patients, the first thing I'll always say is, and I don't mean to always be the bad guy in this conversation, but I think it's always better to work off of information. And the things that we talk about with the family members, the spouses, is number one, is there a healthcare proxy? If you'd hate for something to be in someone's name, the house, the car, the bank accounts, and all of a sudden they're not able to make appropriate decisions. But then the spouse has difficulty trying to actually go in and change things in the bank or anything else because they're not on they're not on any of the leases, deeds, or so forth. So I think it's always worthwhile getting a healthcare proxy. I think it's worthwhile speaking to an estate attorney to see what rights you have. One of the things I think is extremely important is, are you a veteran? If you're a veteran, then what's available for you for services if it would come down to it? One of the things that I think is really, really important, and I bring this up nowadays so commonly in conversations because I think it is incredibly important, is unfortunately nowadays we're all prone to scams. I mean, I'm sure everybody here has received a spam call and someone wanting to sell you something or told you've got
every day
a ticket that's outstanding and you must. Well, think of the situation where you can't really interpret that information and you feel that you're going to be put in trouble or the IRS is going to come after you and you're scared. And because you held the household for all these years, you want to make sure that everything's in place. And what we're seeing, unfortunately, and this is what really upsets me, is we're seeing the elderly being scammed. And so what I suggest is that you put limits on credit cards. Like have a credit card, but put a limit of $200, $150, whatever you deem or feel would be sufficient that wouldn't impact on you if that was to go away. If you can, limit the bank accounts, because I've literally had a patient who was walking into the bank, taking out $10,000 to pay people that were sitting at the curb with a scam.
So incredible.
There was an astute bank teller that said something is not right here. So these are relevant situations. Then there's people calling up saying, I am your son and I am being held in prison because this, and I need to be taken out of prison. I need X amount of money. And
And if you have some mild cognitive impairment, not even full-blown Alzheimer's,
correct,
you're going to go to the bank, take out the money,
correct.
and fork it over. Yeah.
And while you say, oh, come on, that can't happen, unfortunately, and I can't emphasize this enough, it happens more commonly than not, to the point where I actually discuss this with every single patient that I have.
Yeah, I think advanced directives, obviously,
Correct.
but I think they should be done, obviously, with a person. In other words, if you've diagnosed Alzheimer's and they're beginning to show signs of, let's say, we've gone beyond normal aging now, we're in mild cognitive impairment. I think the time is to sit down with the loved one, the family, and whoever else, legally, the attorney, so on and so forth, and to kind of calmly discuss things lovingly. I would think tell the person that, Mom, Dad, we love you, and you have this disease, and I think we should take care of certain things now where they're calm and their behavior isn't erratic.
I think your point is, I always tell individuals, plan as much as you can in advance for safety and well-being, because you can never anticipate anything or everything that's coming down the pike. And to your point of what you're saying is to do things in a calm manner. And I always tell patients and family members, if you do things under duress, you've made the wrong decision. Going back,
not only that, but if you're not loving and calm, then you're going to agitate that person who's already got this cognitive impairment, and it's just going to make the situation worse. Their behavior will change. They'll become more angry and kind of more irritated.
Yeah, I'm going to actually go back and say something slightly to disagree with what you're saying. And I know that you agree with me because we've had many discussions like this in the past about living wills. And people ask, when's the right time to do a living will? And I always say, well, if you're asking that question, this is the right time. I'm a firm believer of doing it as early as possible. Like, I have a living will because it's not anything negative or bad. It's just that I am aware that if things occur, I don't want certain things done, or I do want certain things done. So I think that's a very important aspect to actually document and get out there.
Yeah, I agree with you. Yeah, I agree with you.
So continuing on with what you're saying, one of the things that we don't really take into consideration because we don't really think about things is, behaviors that we've got to be aware of. Number one, falls. You could have cognitive issues and you could still be very, very good for many years until you fall. And then things go downhill. So I talk a lot about fall prevention. Look around the house to see what can impact a fall, like area rugs, the transition between a carpet and stairs, objects that people can trip, low coffee tables. I also talk about
the triggers.
Yes.
The triggers, yeah.
Wandering from home. Does someone go outside and say, why am I outside? And then they just continue to wander. So are there locks that can be put in place? Nowadays with technology, there are cameras you can place to make sure, I'm not talking about in the bathrooms and so forth, but in the living room, there are cameras so if you have to leave, you can keep an eye on your loved one. Other aspects, talking about safety around the house. Many people have guns. And as the memory and overall awareness changes, sometimes someone may recognize someone as a foreigner or a stranger.
Yeah.
And
shoot their own family member. Yeah.
And you'll see throughout the country there's been documentation of individuals who have either been shot or they've been stabbed because they thought there was a stranger in the house. So I always say, and people get shocked at what I'm asking when I say, do you have guns around the house? They're like, why are you asking that? And I explain. And I say, well, even though there's a safe, it's wise and advisable to get them out.
Yeah. So basically, when we're trying to treat the behavior, we have to use all means non-pharmacological
Correct.
necessary first.
Correct. Keep things
Everything.
simple.
Whether it be the sleep, whether that person is constipated, depressed, like, we went through depression, loneliness, falls, whether they need a caregiver or not, all that stuff.
Absolutely. One of the most important things that I always say is keep a schedule. Because people will say to me, well, he went to sleep at 6 o'clock and he's awake all night. Well, what do you mean by awake all night? Well, they're up at 2 a.m. Well, they just slept 8 hours.
Yeah.
So I think it's extremely important. This is one of the most difficult things that we do or people have to do is they're sleeping at 8 a.m. Well, yeah, but they had a rough night, so let them sleep. Then you start shifting the day-night cycle, and then
It's all screwed up. Yeah.
Keep a schedule. Yes, wake them up at 8 o'clock in the morning. Exercise for 10, 15 minutes. Have breakfast. Let's do an activity. And I know this takes, and we talk about in the beginning about resources. This is where resources are very difficult, and the continuous part of keeping someone active. So by the time 9, 10 o'clock comes around, like, I'm going into bed because I'm tired. Right. Schedules are extremely important. Yeah. We are creatures of habit.
Absolutely.
But yet then we just lose the habit, and people just lose track of what they're doing and end up just sitting watching television, falling asleep all day, and then awake all night.
Yeah.
So it's extremely important to keep people on track.
And obviously, if non-pharmacological events fail, okay, what medications that you know of or that you've used would say are beneficial to people who are having these behavioral disturbances?
So I have patients where the spouses say he or she acts out. And instead of saying, here's a pill and I'll see you later, goodbye, say, well, what do you mean by acting out? Well, they get angry or upset. Well, who doesn't have a spouse that doesn't get angry or upset at times? But tell me more about it. And it's always good to get in, well, I did something, or I asked them, or I corrected them on something, and they got upset. And I said, well, were you able to calm them down and keep them on track? And I'm like, yeah. So the whole point is, are there behavioral modification techniques that we can do so that we can calm someone down? Like keep the lights on at night so that, or a little bit later so that they don't have that sundowning aspect. Are there things we can do just to calm things down? Like, is there music that all of a sudden that person loves music, so when they start getting a little agitated, you just put on the music? Right. Is there foods that you can distract and keep them like that? And many times we can by doing just non-pharmacological methods. But when I always ask, is it becoming to the point where it's harmful to you or harmful to themselves or the community? Then that's when we start saying it's probably better to start a medication. And nowadays we have one medication, Rexulti, that is approved for agitation with Alzheimer's disease, and it has been shown to be effective. But we have many other medications, such as Risperidol, Seroquel, that can be used.
Right.
Obviously with warnings that they can impact sudden death, cardiac rhythm abnormalities, falling, but nevertheless they are used because it's a balance of safety versus use of medication.
Do you use anything if they become really apathetic? Just kind of...
It's very hard.
They just don't want to do anything and just kind of slumped over in their chair, almost like a severe, deep depression.
Mm-hmm. It's very, very difficult because obviously the stimulation, light, being outdoors is a very, very, very big motivator for people to do things. Music, even pets. But when these things don't work, sometimes we go to the the antidepressants that will help.
Right.
And I do this quite commonly where I will add on an antidepressant to the medication regime to give them a little bit of a spark, a little bit of happiness.
Something like Ritalin too as well, or no?
A lot of times I try and avoid Ritalin because of a lot of times in the elderly patients, they can have cardiac rhythm abnormalities and so forth.
Right.
I will try, I mean, yes, in a very rare incidents, but I try and avoid these.
So, as far as new emerging treatments, is there anything you're excited about? Is there anything that you feel that's on the horizon?
So I'm always very excited. I'm always very hopeful. And I think the biggest aspect is the two medications that we use IV form for to bind to the amyloid, which is Kinsula or Leqembi. And these are medications that are just recently approved and they've been in effect and been shown to slow the decline. And I emphasize slowing of the decline because unfortunately at this point in time, there is no cure. There are other medications in the pipeline that are very, very similar that obviously hopefully they'll be in a more easily managed form such as an injection or a pill form. There's other investigation and investigational drugs that are out there that are looking at completely different pathways because we all say, well, there's buildup of waste protein in the brain. We're going to give a medication to bind to that and remove it in a very simplistic manner. And obviously they've been shown to be effective. But there are other companies out there that are saying, well, maybe that's not the cause because we know the individuals, the scientists that have been proponents of tau argue with the proponents of amyloid, and the battle's gone back and forth for decades. But then there's a new emerging field where people are saying, you can argue all you want. We think there's something else that's causing this. And that goes into the gut-brain pathways, where we're saying, should we be targeting the gut and the microbiome of the gut that would help prevent diseases that are neurodegenerative, such as Parkinson's, Alzheimer's? And I think that's where the emergent therapies are going.
Yeah.
But talking more about, we have to bring in AI and technology into this because, everyone loves AI, but they're not sure how they want to address this. And I think in evaluations and picking up on cognitive issues before the patient or their spouse or family members are even aware of this. And there's large language models that are able to predict or determine that someone is having a cognitive issue just by their speech pattern, by the inflection in their speech, by the pauses between words. And these are the emerging fields. Now, before we've always
That's
said,
amazing. It's amazing stuff.
It is more incredible. And as we're getting more and more computing power, we're starting to understand the power of these tools in our armamentarium. Now, I know in the past we've always said, we'll fill out these surveys and do these quizzes, and we'll be able to tell you if your cognition is going down or you're having impact of memory. And people would do these things and do them for a little bit of time, and then, like everybody else, they get bored and I don't need to do it anymore. I think the emerging field in medicine nowadays is how to diagnose and treat people passively so that the patient's got no involvement whatsoever in terms of their diagnosis or overall decline, if indeed it's there. And it's being done by machines that are actually monitoring. So if I put a microphone on the desk or somewhere in the house, and it's just ambiently monitoring your speech and your interactions and even your activity level. And then all of a sudden you're getting a call from the doctor saying, I think you need to come and see me. Over the past 3 months, we've started to notice that your speech has changed, that based on the characteristics of your speech, I think your memory is starting to be impacted. But in addition, we're correlating that with your activity level, and your actual step has decreased in size or height.
Has that been done yet, Paul?
There are some things that have been done with ambient listening from memory and looking at voice recognition for neurodegenerative processes. There are models out there for schizophrenia, for example, that will say, based on the rapidity of the speech, the words that are being used, the inflections in the tone, they'll know if someone's going into a schizophrenic crisis. So the answer is yes.
Wow, that's fantastic.
Yeah.
Wow, wow, wow. Huh. And so, I think I wanted to discuss a little bit about caregivers, and we know
Yes.
how their importance is, right? And, when someone's a caregiver for an Alzheimer's patient, they have so much stress and anxiety, I believe, because caring for someone like that all day long has got to weigh on you,
Absolutely.
right?
And I'm going to look at the camera for this one because you are really the unsung heroes, whoever's listening to this. Because in my office, I am always saying, I see the patient, I talk to the patient, do everything, but I'm always turning to you and saying, how are you doing? I think I could not agree with you and emphasize more about the importance of the caregiver. They are not only the heroes, but they are the ones bearing the brunt of everything. And while the families nowadays, I know that we're always so diffuse and dispersed, and the family members are always calling in from California, hey, how's dad doing? Mom's doing
Right.
well, and everything else.
Right.
That's not always the case. They're suffering and they need the support and they need the help. And I always refer individuals to number one, if they are a veteran, what resources are available through the VA? Number two, is there a policy that they've paid into all their lives that people, many times, I'm always asking, do you have a policy, an insurance policy for care? And they're like, yeah. I'm like, well, you need help, enact the policy. Then there's other aspects like the Alzheimer's Foundation of America, the Alzheimer's Association. There are resources out there and sites that are specifically geared to give you information and able to get help. Look at your local governmental agencies to see if indeed there's day programs that you can be taken to. One of my patients that I saw last week, she goes 3 days a week to a day program where she's socializing, she's interacting, and she loves it. And it takes some time away from the families that they can actually go shopping, get their hair done, just basic things. And some of the things I always say that is very important, I always tell the caretaker, stop with the guilt, which is really important because I don't want to go to the hairdresser. I don't want to go see a movie because it's not right. How can I
So
do
the key
this?
tip
Yes.
for caregivers is
Take care of yourself.
take care of yourself.
Yes.
That's the takeaway.
I always,
You need
yeah,
a certain amount of time in the day to say, hey, Mom, watch this show, which she likes, for 30 minutes. And while she's doing that, you can do something that relaxes you.
absolutely. I always equate it. You are the prize fighter. Now, a prize fighter, if they're sleeping, eating, resting, getting someone to pamper them, that's okay because when they get into the ring, they're on. And
Right.
you're getting into the ring and you're on. So for that, you have to be at your peak performance. So for that, you have to rest well, eat well, sleep well,
Right.
and really take care of yourself.
And what would you say is one actionable step that a neurologist would recommend to a primary care doctor that they can do tomorrow regarding Alzheimer's dementia?
I think one of the most important things that is really not too recognized, because we always think, oh, they're 80 years old, they're coming in, they have Alzheimer's, we can send to a neurologist or I can start with the workup. I would emphasize the age and look at younger people, because I personally am noticing younger and younger individuals. And one of the myths that we want to talk about is Alzheimer's only occurs in elderly people. It doesn't, unfortunately. There are individuals in the 40s and 50s that have Alzheimer's disease. So I think one of the short-term important aspects is that if you have young patients that come in with that complaint and other people corroborate that, where family members, brothers, sisters say, yeah, something is not right. It's not just the fact that they couldn't function at work. Address that. And that's one of the short-term items I would like to convey to primary care.
So would you say, give everyone a 2-minute cognitive test?
Yes, it's easy enough, simple enough.
Right.
Yes.
Yeah. Because only 50% of dementia is diagnosed in primary care,
Yeah.
which it should be way, way higher than that.
Correct.
It shouldn't be where a neurologist calls a primary care doctor and say, oh, well, your patient of 20 years that you've been seeing, 3 times, 4 times a year has Alzheimer's dementia. That's what happened to last year, the year before.
Well,
Obviously, in certain instances where there's rapid deterioration.
Well, what happens is the person comes in, and you know them for years, and it's, how you doing? Everything's great. What have you been up to? Nothing much, here and there and so
Right.
forth. Okay, you've got high blood pressure. Let me refill the blood pressure medications, and that's it.
Not knowing that high blood pressure, risk factor, right?
Right.
You're diabetic, risk factor, right?
Age,
Risk factor. Female, risk factor.
social isolation.
Social isolation, risk factor. Maybe
No
a genetic
exercise.
variant, risk factor, right? So,
Right.
I mean, you see this, but you have to connect the dots,
Right.
right? And
And it's simple. And even if you don't connect the dots, even if you just say, well, my medical assistant or someone's going to do this quick test on you.
yeah. And what would you say is one myth that most neurologists want people to stop believing regarding Alzheimer's?
That's a good question to encompass all of neurologists. But
Or most neurologists,
I would say that personally, I hate the word Alzheimer's disease. And I always try and refrain from using it in my office because people say, well, I've got Alzheimer's disease, so that's it. I've got nothing I can do about it, and this is my pathway going forward. That there's no modifiable things that I can do. To me, that's the myth.
And so basically, you're saying that Alzheimer's is not a normal part of aging.
Correct.
And
But there's things that
and
can
people
be
are
done.
told that it is when it's not.
Correct. And there's things that can be done. Okay, you have Alzheimer's. We understand. The memory's not as good as it should be. But now let's see what we can do to keep you active and good and change the pathway such that you are not going to say, oh, I've got Alzheimer's, so I'm not going to eat well, sleep well. And as for my medication for blood pressure, I'm not going to take it because it's not going to make a difference. And it's to reframe everything that you have to now, well, because you have this,
Everything counts.
everything counts, but you have to now act more and behave differently. If a baseball player injured their shoulder, then they have to work harder on that shoulder to make it better. So you have to, with memory issues, have to work harder. So if there's hobbies, clubs, things out there that you can do, instead of saying, I don't feel well, it's raining today, I'm not going to do it. Nope, the answer is, I'm doing it, because that's what's important.
Right.
And that can change the trajectory of a disease.
Paul, this has been a great conversation.
Marvin, this has been wonderful. It's so
Yeah.
good seeing you. And
Nice seeing you. And
we could talk about this
yeah.
important topic for
hours. Yeah. But I think we'll wrap it up and then we'll do a part 2.
Okay.
All righty. It's been nice seeing you.
Likewise.
Thanks for coming. Thanks
Thank
for
you.
your time. Thanks for your expertise. Okay. And to everyone else, if you found this podcast helpful, please share. God bless and goodbye.
Refrain from using it in my office because people say, well, I've got Alzheimer's disease, so that's it. I've got nothing I can do about it, and this is my pathway going forward. That there's no modifiable things that I can do. To me, that's the myth.
And
that-
so basically, you're saying that Alzheimer's is not a normal part of aging.
Correct.
And-
But there's things that
And
can
people
be
are
done.
told that it is when it's not.
Correct. And there's things that can be done. Okay, you have Alzheimer's. We understand the memory's not as good as it should be. But now let's see what we can do to keep you active and good and change the pathway such that you are not going to say, oh, I've got Alzheimer's, so I'm not going to eat well, sleep well. And as for my medication for blood pressure, I'm not going to take it because it's not going to make a difference. And it's to reframe everything that you have to now, well, because you have this,
Everything counts.
everything counts, but you have to now act more and behave differently. If a baseball player injured their shoulder, then they have to work harder on that shoulder to make it better. So you have to, with memory issues, have to work harder. So if there's hobbies, clubs, things out there that you can do, instead of saying, I don't feel well, it's raining today, I'm not going to do it. Nope, the answer is, I'm doing it, because that's what's important.
Right.
And that can change the trajectory of a disease.
Paul, this has been a great conversation.
Marvin, this has been wonderful. It's so
Yeah.
good seeing you. And
Nice seeing you. And
we could talk about this
yeah.
important topic for
hours. Yeah. But I think we'll wrap it up and then we'll do a part 2.
Okay.
All righty. It's been nice seeing you.
Likewise.
Thanks for coming. Thanks
Thank
for
you.
your time. Thanks for your expertise. Okay. And to everyone else, if you found this podcast helpful, please share. God bless and goodbye.